Okay, this is chapter 19, the postpartum woman at risk. So we're going to talk about the things that can go wrong with postpartum moms. So the last chapter we talked about what is normal physiological and psychological changes. Now we're going to talk about some things that can go wrong that are more significant, that we could have some problems with. And this chapter is a little bit long, so if you need to take a break in the middle, feel free to take a break. Some of the things we've already talked about, but we'll be talking about them a little bit more at length in this chapter. So a lot of times, we consider pregnancy 3 trimesters, but a lot of times we think of that postpartum period as being that 4th trimester, that 6 weeks after delivery, because this is when other kinds of things can happen. Most of the time we don't hear a lot of things happening after delivery, but there's always that 1 or 2 that can become very, very ill. There are mortality rates on moms postpartum, so it's something that we need to be aware of and not just kind of blow things off when something comes up that may have a red flag in your mind. So as our bodies go through these physiological and psychological changes to come back to that pre-pregnancy state, most of the time they occur without any kind of complications. However, there are some complications that come afterwards, and we have a couple that we're going to just discuss kind of briefly, but hemorrhage, infection, DVTs, and certain mental disorders, which we've kind of touched on in the previous chapter. We'll touch on a little bit more. Also postpartum grieving and maladaptation are also potential things. If you got a mom that's grieving, maybe she has a baby that didn't turn out like they thought they would. Maybe there is some cognitive disorders. Maybe there's a physical disorder. Maybe the baby has Down syndrome. Maybe the mom's not attaching with the baby like they should. So there's a lot of things that can go on psychologically too. Postpartum hemorrhage. There's a couple different kinds. There's early postpartum and there's late postpartum. So early postpartum is going to occur in that first 24 hours right after birth. It's usually caused by uterine atony. What does uterine atony means? If you break down atony, A means without, tony means with tone, so that uterus doesn't have any tone. This is when that mom is going to be the most vulnerable for this. It's the greatest risk that very first hour after delivery. So it's imperative that we watch that mom very closely because it can happen very, very quickly, and we have to be able to respond very, very fast. Late postpartum hemorrhages, these are something that can occur anytime after that first 24 hours and go all the way through that 6-week postpartum period. Now, blood loss usually will give us a hemodynamic change if it's greater than 1,000 milliliters. We know that in a normal vaginal delivery, 500 milliliters is kind of average. In a C-section, it's 1,000 milliliters is considered average. So you get a mom that's had a C-section and maybe she had an additional bleeding through the C-section. She's had a 1,500 milliliter blood loss. We might see a little bit more of those hemorrhage type symptoms in somebody like her. So the major reasons we're going to have those postpartum hemorrhages. Number 1, uterine atony. That uterus is not clamping down like it should. Trauma. Maybe there was trauma during delivery and we've ruptured an artery or something. A platelet dysfunction. Sometimes coagulation factors can become a problem if you get an infection or you get something where the platelets become dysfunctional and they don't clot anymore, and you can get into a hemolytic problem. And retained placental fragments. This is where we've delivered the baby, and we might not know this yet, but not all of the placenta comes out, and there's certain fragments of that placenta that are left inside there. So early postpartum hemorrhage, usually number 1, early postpartum hemorrhage is usually uterine atony, lacerations, and hematomas. So think of your lacerations. You got a mom that maybe she stalled during delivery in that, the pushing stage, and they weren't able to get the baby out, and they ended up using some forceps, and maybe the forceps caused some trauma of the vaginal wall, and maybe there's a laceration in there on the cervix that we're not aware of. Sometimes a hematoma can form in there, and those can collect a unit or 2 of blood, and we don't always see that. It's underneath that skin, and we just start seeing signs of hypovolemic shock, but we don't know where the bleeding is coming from. So we're looking for those. But they are at risk for developing hypovolemia, hypovolemic shock, anemia, and sometimes this can go into the need for hysterectomy if we cannot find what's going on or the doctor just cannot stop the bleeding. So clinical manifestations are how that mom's going to present. Well, it's going to depend on the cause. If it's uterine atony, that's just going to be where the uterus is not contracting like it should, and we're going to treat that differently than we're going to treat a laceration or a hematoma. So, early postpartum hemorrhage. How are we going to diagnose it? Well, when it comes to the first things that you're going to see, mom's going to have that pallor. She's going to be very kind of pale, maybe some lightheadedness, some weakness. She might have some palpitations because just lack of blood in the body. Restlessness, change in that level of consciousness. She's not getting the oxygen level to the brain, so she's going to get a decrease in her level of consciousness. The decreased hemoglobin hematocrit, changes in your clotting times. Now, your hemoglobin hematocrit sometimes might not be totally accurate when you get it because it may have lagged a little bit. So it could be actually lower than what we're seeing. So treatment, correct that underlying problem to control the hemorrhage. So whatever the hemorrhage is or whatever the cause, we have to correct that cause before we can do anything else. So if we have uterine atony, the biggest thing we have to do is massage that fundus. Massage, massage, massage. If it's retained placental parts, they're going to have to go in and do a D&C and get all those placental parts out. Now, how are we going to contract a uterus that doesn't want to contract? Well, the drugs. So we're going to have to use certain types of drugs. So oxytocin is one. Methadone is another one. Methergin is the trade name, so you won't be using that. It'll be methadone. Now, the biggest thing with that one is, we've talked about that before. I always think about, methadone. We can't give that if they have hypertension. So I always think about meth, and meth causes hypertension. So methergin, we can't use that with hypertension. It's just something I think about. Misoprostol, Carbapost, and TXA, all of those are uterine stimulants. So they're going to stimulate that uterine. TXA is a fibrinogen product that builds fiber to help stop that bleeding. So it's a little bit different of a drug than the other ones. Lacerations and hematomas, the only way that we can really fix those, they have to go in and surgically be repaired. Ice and analgesics. So those are the things that we're going to do if we see something like that. Now with lacerations, a lot of times you might not know it initially, and you'll just keep seeing a trickle out the vagina. And it's like, okay, I just wiped her and I've got this bright red trickle. You should not have a bright red trickle. You might have drops, but it should not be a bright red trickle. Hematomas. Sometimes if you look at that perineum, you'll see one side that has a real dark blue, looks like a bruise on there, and that's actually hematoma forming under the perineum. And that can actually hold up to a unit or 2 units of blood. So those are things we need to know about to make sure that we can get that bleeding stopped. Okay, so late postpartum hemorrhages usually is because of retained placental fragments, or the uterus is subinvolution, where it's not going down like it should. That can be from retained placental parts, that can be from infection, anything like that. So how are these moms going to present later? They're going to have that increased bleeding. So that lochia rubra has came back. The uterus is not really good and contracted. The lochia is heavier than they thought it should be, and they've got back pain, they're fatigued, pelvic pain, it feels like something really heavy in there. They might have a fever, and usually that lochia is going to be foul smelling because things are not contracting down like they should. How are we going to diagnose it? Well, they're going to usually have a low hemoglobin and hematocrit levels. If they have retained placental parts, they're going to have a positive pregnancy test because that placenta is an organ and it produces the HCG hormone. So if there's still some of the placenta inside there, it's still going to be producing the HCG hormone. So they're going to have that positive pregnancy test. The ultrasound is going to kind of show that we have those retained placental fragments in there, and they're probably going to have an elevated white blood cell count. Anytime something stays inside there that's not supposed to be there, eventually it will set up some type of inflammatory response, which can eventually lead into some type of infection response. So how are we going to treat it? Well, we got to treat the underlying cause first. So if they're hemorrhaging, we might have to give them some oxytocin therapy, try to clamp it down. But most of the time, we're going to probably go in and we're going to do a D&C. They're going to do a dilation and curage, and they're going to dilate the cervix, and they're just going to clean everything out in there. surgery like a hysterectomy is going to be the last resort. No one's going to go in on a 23-year-old female that just had her first baby and she's got some hemorrhaging and go in and do a hysterectomy unless it is life or death situation. We're going to try everything possible first. If it's an infection, we're going to treat it with antibiotics. So nursing care, just make sure that you are aware of all the information that you're getting from your patient. Make sure you're knowing about those danger signs. Make sure you're listening to that patient. Make sure you've told them to call if they have any of these types of things. So education before they leave is going to be very, very important. Okay, so early hemorrhage. Oxytocin, it's a uterine stimulant. It's going to clamp down that uterus. Now, problem number one, sometimes what can happen with uterine atony, if we've got a mom that's been on oxytocin for a long time, her uterus is completely worn out. It's completely worn out, so the uterus will not contract. If the uterus doesn't contract, it just stays dilated and they can't get it to contract. So sometimes oxytocin is not our drug of choice, or maybe that mom's had a super 24-hour severe contractions, and the uterus is just tired, and it's like any other muscle, it's fatigued, it's not going to contract anymore. So we might have to give that methadone, and again, that one we can't give if they have hypertension. So you always want to remember that I always think meth causes hypertension, so methadone you wouldn't give if they have hypertension. So that's just the way I kind of remember it. Misoprostol, it's also a uterine stimulant. So it's going to be something that we're going to use to stimulate that uterus to start contractions. Carbapost is another one that's a uterine contraction. I already talked about the TXA, or the tranexamic acid. That's an antifibrinolytic, so it stops the formation of those fibers and gets things to go. So it improves that blood clotting. So anytime we start to look at anything, always look at your nursing process. Assess, assess, assess. Always do your assessment. Look at your patient thoroughly. Make sure you're documenting everything. Make sure that you're looking at everything. Then what is my focus? What is my nursing focus? What do I need to focus on right now? And then what's my plan? What is my goal? What do I need to do to reach this goal? And that's your implementation. What are we going to do to reach your goal? So, and then evaluation, did we reach our goal? Did we make it through to that goal? So let's look at infection. So if we're going to look at postpartum infection, we got to look at what we used to call these. We call them postpartum infections, but they're also called puerperal infections. It's just the pubertal period is just the part of the postpartum period that we call that. It usually involves the reproductive tract. So it can be anywhere in that reproductive tract. So it might be the breast, it might be a uterus, it might be a C-section incision, it might be the urinary tract, it might be somewhere that we've got an infection. Usually these moms are going to come in with a fever over 100.4. Usually it's going to be staph, strep, E. coli, chlamydia, or another common organism that we see. Now, the biggest thing about infection is a lot of moms will come in now and they're all excited to have this baby, and they get into an emergency situation and the doctors have to go very quickly to save the mom and the baby's life to get the baby out. Well, a lot of times we're moving as quick as we can, and when you've got a mom and a baby's life at stake, we're probably not using those the greatest infection control measures. A lot of times we're just slapping on a sterile sheet and we're just going for it because we've only got so many minutes to get that baby and that mom stabilized before we can get into some, life and death situations. So, not having that sterile stuff available is one of our major risk factors. Poor aseptic technique. Maybe the nurse isn't using aseptic technique. Maybe when she put in the catheter, they weren't using sterile technique. Maybe mom's not wiping good, so teaching mom to make sure she's wiping front to back. And that infection can also spread to other tissues, so we want to make sure that we catch that very early on. Antepartum, we have antepartum, we have intrapartum, and we have postpartum. So our antepartum is before we have the baby. Intrapartum is during the process, and postpartum is after. So antepartum, before the pregnancy, before our pregnancy. Do they have a history of infection? Do they have a chronic condition that we need to know about? Do they have diabetes? Do they have something that causes their immune system to be lower? Do they have an infection in the genital tract? Do they have chlamydia? Do they have gonorrhea? Do they have herpes? Are they a smoker? Are they obese? Are they on any immunosuppression? So that's antepartum. What is going on with them before they become pregnant that increases their risk for any of these types of infections? So intrapartum, that's where we might have a non-elective cesarean section. So we went and did the cesarean section, and we weren't able to do that 5-minute scrub on their abdomen, and we just had to go for it. Maybe a catheterization that wasn't sterile, an episiotomy that got infected, a laceration, all the vaginal exams that we do, retained placental parts, chorioamnionitis, all those instruments that we have to stick up inside there. What if one of them wasn't super clean? What if there's something going on in there? We're sticking monitors up there to measure fetal heart rates. We're sticking this up there to measure their contractions. So there's a lot of things that are going on down there that can cause a lot of infections. So postpartum, hemorrhage, manual exploration of the uterus that can cause infection because we're going up inside there, and the development of a hematoma. Okay, so endometriitis. This is just an infection inside that endometria or that deciduous lining. So it's an infection of that uterine lining. It's the most common that we're going to see. A lot of times if we know that there's an infection or they got anything like that, we're going to use prophylactic antibiotics. So if you have a mom that's come in for a delivery and she's got positive group B strep, we're probably going to go ahead and give her prophylactic antibiotics. If we got a mom that isn't group B and everything's going fine, we may not give her anything. If we have a mom that is going for a cesarean section that's an emergency, we're probably going to give her prophylactic antibiotics because it had to be quick, and we went in there and maybe things weren't as clean as we wanted them to be or sterile as we wanted them to be. So those things will just help decrease any types of infections afterwards. So what are they going to come in with? They're going to have fever greater than 100.4. They're going to have uterine tenderness. A lot of times they're going to have tachycardia just because of the infection, the fever, the white blood cell count, all those kinds of things. They may come in with a midline lower abdominal pain because the infection's down in that uterus lining. So how are we going to diagnose endometriitis? Well, we're going to look at their CBC. Is it elevated? What is their white blood cell count? Now, the biggest thing, we're going to look for a left shift in their differential. So when you look at a white blood cell count, the white blood cell count might be 20,000, but we're going to look at the different types of white blood cells. So we have neutrophils, we have all these different kinds of things that we look at. So one of the big things that we look at is if they have bands. If they have bands, that usually is an indicator of some type of infection. A lot of times it's based on signs and symptoms. So if the moms are coming in and they got fever and they got abdominal pain, we're going to go ahead and treat them for infection. And we're going to go in and maybe have to explore. The doctor comes in and he can't really find anything obvious on the pelvic exam, or he can't find anything that's going on. He may have to go in and, look at things and maybe do, scrape the uterus and do a D&C and maybe do like a culture of the contents. So treatment, we're going to treat those with antibiotics, mainly cephalosporins, penicillin, gentamicin, oxytocin agents. So we're going to clamp down that uterus again. We're going to give them analgesics. We're going to give them lots of IV fluids. As far as nursing care, we need to make sure they get their antibiotics. We need to give them very good comfort measures, alleviate anxiety, and give them lots of education. Teach them about when they go home, what they need to do, washing their hands, make sure they're changing their perineal pad, no tampons, no sexual intercourse. Make sure they're cleaning their breasts off after the baby feeds. All those kinds of things. Make sure they're cleaning their pump parts. All those kinds of things that can set up an infection. So a wound infection. Typically has something to do with your episiotomy, the laceration, or your C-section incision. So it's going to be one of those kinds of things that we're going to get an infection of a wound. So risk factors is going to be infected lochia. If the lochia gets an infection in it, if you get fecal contamination in the wound, especially with an episiotomy or something like that, we shouldn't really see it with your incision, your cesarean incision, but you could. Lacerations in the the vaginal area, you might see those. And maybe we just got inadequate hygiene measures. Maybe mom just isn't wiping good, it hurts, so she's not wiping. So we need to teach her about the peri bottles, make sure she's using those. Clinical manifestations. A lot of times if you get a mom that has a hematoma, she has a large hematoma in there, she's going to have more pain than what you think she should be having that is expected. So you'd be thinking, why is she having such a great deal of pain? There's got to be something else going on here. This is not normal. So they would have more pain than expected. That area might be very red and angry looking. Sometimes that wound might have edges that are separated, foul-smelling discharge, might even have some purulent discharge. Uterus might be tender, fever, generally just doesn't feel well. So if they come in with a wound infection, how are we going to diagnose it? Well, you can look at it and you can see, that there's redness, swelling, edema, but that could just be an inflammatory response. So we're going to look at their CBC count. We're going to look at their white blood cell. We're going to do a culture of any types of drainage that are coming out. We're going to look at an ultrasound. We can see those, any pussy buildup or anything inside there. Treatment, antibiotic therapy, and supportive therapy. Supportive therapy is just making sure that they get the ice packs, making sure that they're getting the Americaine spray, making sure that we're giving them comfort measures, making sure they're getting plenty of fluids, eating healthy, make sure they're increasing their protein, all of those kinds of things. Warm sitz baths, warm compresses to the perineal area. Document. How is their progression going? Is their wound looking better? Is it looking worse? Mastitis. This is an infection of the mammillary glands. So this is a lot of times due just from contamination of the nipples, whether, from mom's hands, maybe she changed her perineal pad and then touched something, or maybe there's a clogged duct that got an infection in it or something. So risk factors for mastitis: poor hygiene, cracks in that breast tissue. If the milk sits in those ducts for long periods of time, it can set up an infection. It's warm, it's moist. Engorgement, any cracked nipples could give way to infection. Nipple piercings, when they, all of that can do that. Pressure on the breast from too tight-fitting bra or an underwire bra. You want to wear a good snug bra, but you don't want it to be too tight where it gets pressure, but you want a good fitting bra. Clinical manifestations, usually the moms will complain about feeling like they have fever. They will have one side of their breast that's going to be very, very tender. It's going to be red. It's going to feel heavy. It's going to hurt. And it's going to have one little section of redness in there. So how do we diagnose it? Usually there's really no specific test to it. It's just based on signs and symptoms. They will usually have a pretty high fever. So they usually have like 101.5 and they feel like they've got the flu, but they've got this real painful area on one breast. So supportive care, analgesics, warm compresses to the area. We tell them to continue to breastfeed even with their antibiotics, even with the mastitis on that side. The baby will do a very good job of pulling that breast milk off. So we want them to do that. They can use a shower. They still need to pump and make sure they get all the milk out of that duct so it doesn't have time to sit there and increase that infection. So continue that breastfeeding. Make sure they take their antibiotics. If they're not breastfeeding and they get mastitis, they might need to manually express a little bit or pump a little bit off just to make it more comfortable. Analgesics is going to be like Tylenol, lots and lots of fluid intake. If it's something that is recurring, they might want to send them to a lactation specialist just to make sure that they get that treated. Urinary tract infections, pretty common, just because of the hygiene factor and all the things that have been going on in that area. A lot of them have had catheters. They may have had an intermittent catheter, a lot of hands down there, a lot of stuff happening, a lot of stuff. that could be part of it. So clinical manifestations. So if you think about cystitis, that just means inflammation of the bladder. This is where they're going to get the urinary frequency, urgency, burning, maybe a tiny low-grade fever, maybe a little bit of suprapubic pain. You know, you go to the doctor, they do a urinalysis. Yep, we got some leukocytes in there. We got some blood, nitrates, that kind of thing. Pyelonephritis is a little bit different. Usually cystitis can turn into pyelonephritis if cystitis is not taken care of, because that bacteria will ascend into the ureters up into the kidney, and we get pyelonephritis. This is where they're very, very sick. It can get, they can get urosepsis inside there, pain, very high fevers, hematuria, shaking, nausea, vomiting, flank pain. They can get very, very sick. So how do we diagnose it? We're going to do a urinalysis. If it comes back showing anything, we're going to ask to do a clean catch so we can take it for culture and sensitivity. They're going to do a CBC. They're going to look for any type of elevated white blood cell count. If it's just cystitis, there may not be a lot, but if they get pyelonephritis, we'll probably start seeing some elevation in that white blood cell count. Treatment, antibiotics, antipyretics, analgesics, urinary analgesics, which is going to be like your Pyridium, and it turns turns our urine orange, so we need to let them know about that. A lot of times they get very sick at their stomach, so we might be giving them antiemetics. So we might be giving them Zofran, something like that. Make sure they're drinking plenty of fluids, because that's when they'll end up back in the hospital because of dehydration. Teach them about good perineal hygiene. Make sure they're cleaning everything well. So as far as our nursing care, provide them comfort. Make sure they're drinking plenty of fluids. So how are we going to do that? The only way to do that is by doing their INO. Making sure we're doing accurate INO, making sure we're talking to them about that. And education. Venous thrombosis. So now we're going to kind of switch gears. We're going to talk about something cardiovascular. So venous thrombosis. Venous thrombosis is just kind of an umbrella term that covers a DVT and pulmonary emboli. So a DVT usually starts in the lower extremities. A little tiny piece can break off, and that goes into the pulmonary artery, and that's where we get our pulmonary embolus, or our PEs. The greatest risk, the greatest risk for these is going to be, if I can go back, let's see, the greatest risk for these is going to be those first few weeks after postpartum, when they're not up and moving like they should, or maybe they're obese and they can't really get up real well. So a lot of times after C-sections, the blood, they're not up, they're not moving like they should. So we see them more in cesarean sections. So immediately when they come back from cesarean sections, they should have SCDs on. And those SCDs should be on when they're in bed. So a lot of them refuse them, but if they refuse them, we need to just educate them why they're getting them, make sure they understand the importance of it, and they might not even know what a pulmonary embolus is. So just kind of let them know this is what can happen if we don't do these. Make sure you're getting them up moving very frequently after that C-section. So risk factors, remember our clotting factors are going to increase that last second and third trimester, so it's going to increase those clotting factors. So the blood's going to have more clotting factors in it, so it can set up more DVTs. Pressure of that pregnant uterus leads to the venous stasis, so a lot of blood kind of stays in that venous system. So we're going to get that. Sometimes you might have a mom that was in the pushing position for 6-7 hours, and in that lithotomy position, that can actually create those DVTs. So it's good to know what their history was during their delivery if you're a postpartum nurse. That way you kind of have an idea what went on and what can increase their risk factors. So, the other thing is, what are we going to do medically? What are we going to do for these moms? Or what is another medical thing that can predispose them to this? If they have thrombophilia, if they're more prone to it, if they have hypertension, if they have a family history of DVTs, if they're obese, if they're a smoker, if they're older than 35, if they're bed rest, if they've been on bed rest more than 3 days, or if they got dehydration. So these are all things that as a postpartum nurse, you can be looking at prior to getting that patient from labor and kind of go, okay, I know this patient's probably going to be at higher risk. And so when you guys were in postpartum, we do a DVT risk assessment that kind of gives you an idea where that mom's going to fall in that risk assessment. And if she's going to be higher risk or she's going to be lower risk, depending on a lot of factors. So she might also have an obstetrical history of 3 or more pregnancies. The more pregnancies they have, the more risk that they are for DVTs. If they've had a prolonged labor, if they've had the use of forceps or a cesarean birth, those are going to increase their risk factors. So how do we prevent these? Well, the biggest thing that we can do is those STD hose, early and frequent ambulation. So get them up. If they're not up, make sure they use the SCDs. Explain the SCDs to them because a lot of times they don't even know what they are. Active range of motion. Get them to do those leg pumps, moving their legs around, bending their knees, TED hose. Don't cross your legs. Stop smoking. Maintain adequate fluid intake. All those kinds of things are going to be really important. What is a deep vein thrombosis? It's just a formation of blood clot that's deeper in the veins in the calf, the thigh, or the pelvis. We usually see them most of the time in the calf, but they can be in the pelvis or the thighs. So what are we going to see? You're going to see edema, swelling of that area. So you might have one leg down there that's more swollen than the other. And that's kind of weird. I don't know why I got swelling in one leg and not the other one. They might have redness, warmth, or tenderness in that calf. So tell them, avoid putting weight on that affected leg when walking. It might be paler than the other leg, and you might not even feel pedal pulses as good. These are all things that you've got to get in touch with the doctor and say, I have some concerns. He's going to probably order a Doppler study. He's going to do an ultrasound, a D-dimer level, just to make sure that we don't have a blood clot. So if they're getting SCDs and we suspect that they have a blood clot, we're not going to use our SCDs. We don't want to loosen one and send it off someplace. So we're going to stop all that, never massage their legs, never, massage or anything like that. And if we suspect a DVT, I'd probably keep them on bed rest until we've been ruled out. Okay, so treatment, prevent any further clot formation. So we're going to give them anticoagulant therapy. So they're going to get heparin. They may get heparin, IV heparin. Just remember protamine sulfate is the antidote. It should always be available if you have it, and we need to monitor their APTT. Warfarin is Coumadin, so the antidote to that is phenytonudione, which is vitamin K. Make sure you have that available, and this one we're going to monitor their PT. So each drug is going to work a little bit different on different clotting factors, so we're going to look for both of those things. They may even get, we had a mom that had a DVT, and we were giving her Lovenox up there. So just remember that we may even give something like that. So if they're on an anticoagulant, are we going to give them aspirin or ibuprofen? No, because we know that those have bleeding tendencies already. No shaving, no alcohol. Avoid prolonged sitting. Don't cross their legs, all those kinds of things. So other things, facilitate bed rest. We don't want them getting up because we don't want that to break loose. We might apply compression stockings, but we're not going to do anything that is going to break them loose. Elevate the affected extremity because we want that venous return to come back. Look for any changes in temperature, color, and size. Always check the pedal pulse. Apply warm compresses. Do not massage. Always check their vital signs. Make sure they're getting their anticoagulation therapy. And monitor for any type of bleeding or anything, and let them know that they may go home on some of these anticoagulants. So, DVT, the clot breaks free, travels where? Goes to the pulmonary artery and can create a blockage. If that blockage is severe, it's going to create a cardiovascular collapse, which usually is fatal. So it depends on how big the PE is and where it lodges. So clinical manifestations, the first thing you're probably going to see is a sudden onset of dyspnea. They're like, I can't breathe. And they're going to have chest pain, and they're going to be grasping for air. A lot of these people, if they survive them, they will have this impending sense of doom, like they know something bad is happening, and they feel it. Tachypnea, tachycardia, hypotension, they're going to start, coughing up blood, changes in level of consciousness because they're not getting the oxygen because the pulmonary artery is blocked. So a lot of this is going to be supportive. If it's a major pulmonary embolus, many times these are going to be fatal. Stay with your patient, talk to them, provide oxygen to them at 15 liters per non-rebreather mask, elevate the head of the bed, call for the physician ASAP. What can we do that we can do right now immediately? Diagnosis, chest x-ray, VP scan, pulmonary angiogram, and ABGs. This is if they survive. But many times these are going to be very, very quick. But some people can have little tiny ones, and they just get the chest pain and they get the shortness of breath. So how are we going to treat it? Well, it's very life-threatening. It requires immediate care, supportive therapy. So supportive therapy just means we're going to give oxygen. We're going to give medication to treat any symptoms that they have. We're going to continuously monitor that ECG. They're probably going to get moved to ICU. Call the physician immediately. You have to do something to remedy this. If you don't remedy this, they're going to die. So you have to do something. Elevate the head of the bed to a 45 degrees. It's going to help them breathe better. Stay with, that's a spelling error, but stay with them. Notify your RN, your healthcare provider, give them oxygen, get any kind of lab specimens that they need, prepare for any kind of diagnostics, support your patient is what you need to do. Mental health. So we're moving on to a little bit, mental health has become a big thing that we've talked about a lot now in postpartum that we really didn't realize a whole lot about. Several years ago, back when I was younger, there was several incidents of postpartum psychosis where mothers had, killed their children and they had committed suicide. And just recently, I know my son-in-law, his friend from college called and his wife had committed suicide. They had a 9-month-old child and she just never could get over it, and she wouldn't seek treatment like she should have, and she was embarrassed, and it was really hard. So there's 3 types: postpartum blues, postpartum depression, and postpartum psychosis. And we've kind of talked about each one of those, but we're going to go into a little bit more detail. So the exact cause of these, really, we don't know. We think it's related to a lot of different factors, maybe hormonal, genetic. If you're predisposed to depression ahead of time, it may predispose you to some of these. This is a major life and role change. Maybe they weren't prepared for it. Maybe this pregnancy was a surprise. Maybe they thought they were prepared for it, but by the time they got home, it was just overwhelming because of all the hormonal changes. Maybe mom doesn't have a good support system that she needs to have to be able to get what she needs. Support people at home need to be aware what they need to look for if moms are developing something like this. So we kind of talked about the postpartum blues the last time. This is the least serious. It's kind of that transitory period where they're just kind of sad. They cry a little bit. They might be irritable. One minute they might be happy. The next minute they're crying. Usually it's going to start 2 to 3 days after they've had the baby and usually resolve in about 2 weeks. Now, this one is postpartum depression. It's non-psychotic though, so they don't have that psychosis yet, but it's a depressive disorder. It's in the DSM. It's a DSM diagnosed category. So risk factors: if they've ever had previous depression, if they live in stressful situations, if they have a problem with the relationship with their partner or spouse, they don't have any support system, maybe they don't have an outside support system that they can talk to, maybe it's been unplanned, maybe they have a family history. Maybe there's a history of physical or sexual abuse, intimate partner violence. Maybe they've had a miscarriage, stillbirth. All these kinds of things can play a part in this postpartum depression. If untreated, they can have problems with mom and baby bonding. It can create marital discord and it can lead to maternal suicide. So this has to be treated, and sometimes this can't be treated at home. It has to be treated inpatient. So clinical manifestations, a lot of times these moms just feel a very strong sense of sadness, irritable, and I'm not going to read all of these to you, but these are just a lot of things that they will start to feel. And they get way worse than just the postpartum blues. So you start noticing that they're really getting sick, like something is not right. So how do we diagnose it? Basically, it's signs and symptoms. There's no test that we can do that says, oh yeah, you have postpartum depression. It's based on their symptoms. And these symptoms have to be present on most days for at least 2 weeks. We do what we call an Edinburgh postnatal depression scale. Every mom will get it before she leaves the hospital. If she has a certain level, then we refer them to social services, and social services helps them get the help that they need before they leave the hospital. So treatment, it cannot be by their OB/GYN. They are not qualified to treat postpartum depression. They are going to have to be treated by a trained mental health professional. They're going to have to get, antidepressants, Sometimes they will do ECG treatments. So nursing care, recognize that you're seeing it in your moms, and they go home so quick we may not even recognize it. But make sure that you talk to them about it before they go home. Make sure they know what those warning signs are. Make sure they know they have to get to the doctor. So just be aware of those. Now, moving to the worst one is postpartum psychosis. Now, this one is rare, doesn't happen very often, but it has severe consequences if we don't treat it. It mimics kind of bipolar, where they have the mania and the depression, but they get very confused. They have abnormal behavior. They have psychosis. They may be thinking things that aren't right. They're not sleeping. They're agitated. They're starting to think very unusual thoughts. Symptoms appear very abruptly, and they just kind of come on like that. This is a medical emergency. They need to go to the emergency room if you notice something like this, and they're probably going to be admitted. So clinical manifestations, a lot of times if they have a significant other or if they have a good support system, they're going to recognize this very quickly. If they don't, that's when we're starting to see problems, and we're starting to see, infanticide, suicide, homicides, things like that are severe. So they're going to start having like hallucinations, delusions, just all of this, the weird, the poor judgment, just a lot of things are going to be going on. And usually you can notice these kinds of things. This is where your suicide and your infanticide is going to become very, very important to recognize. So treatment, emergency room. No questions asked. They just need to go to the emergency room for hospitalization. They're going to have some type of antipsychotic agent. So an antidepressant agent probably isn't going to be enough right now. They're going to have something a little bit more. Nursing care, it's going to require special mental health training. So it's not something that your OBGYN can really treat. It's out of the scope of practice. So we need to make sure that they get the prompt treatment, and they need to make sure they get what they need. And we know where we live, there's not a lot of mental health services. So we're going to have to recognize it as quick as we can. Special postpartum situations, sometimes not all pregnancies are going to end like you want them to. There's not going to be a happy ending. Maybe their baby has died at birth. Maybe they've had a stillborn. Maybe they've had a baby that's been born with a major genetic abnormality, and that baby has, maybe the baby has hydrocephalus and it's never going to walk or talk or anything like that. Maybe it's got severe cerebral palsy. So they're not going to have the experience that maybe someone else is having. So not all pregnancies are going to end happy. So that grieving process is going to be very important. They're going to go through Elizabeth Kubler-Ross's stages of grief, denial, bargaining, depression, all those stages. Men and women are going to differ. So make sure you kind of understand both. Maybe you got a mom that's going to put their baby up for adoption. Sometimes this is very complicated. It's very difficult for a woman to have to do that. So there may be some grief involved and some detachment involved when she has to give that baby up. Be very non-judgmental. Be aware of your own feelings. How do you feel about it before you go trying to, help someone else? And, don't ever judge. Someone made that decision because of something in their life that they felt very strongly about. So support them through the whole process. Make sure you know your institution's policies and what state laws that you have on adoption, so we kind of have an idea what's happening. Newborns that have congenital anomalies. These are going to be a real challenge for the postpartum nurse. That mom is going to grieve the loss of having a normal baby. She's going to watch everybody else go out with their normal babies, and she's going to watch everybody else's babies do all the good things, and your baby's not going to be able to do that. And you're going to have to encourage them to interact, bonding with that baby, encourage them to go to support groups. They're probably going to need it. They're probably going to go to lots of different doctors and have lots of different visits throughout this baby's life. If the baby's died, a lot of times, they're unprepared to deal with what this is going to be. They've carried this baby for 9 months and now it's not here. So a lot of times there's not a right or wrong answer. Sometimes it's just giving them a hug, showing them touch, just something that we can do. Help them, collect mementos that they want, anything that they might want, pictures. Can I take some pictures for you? Do you want to do you want to dress them? Do you want to keep a blanket? Do you want to wrap him in a blanket? Do you want to wrap her in a blanket? What would you like to do? Save things for them. Now they can't take certain things. Never say, well, you can have another one, because you really don't know if they can. So, I understand your loss. If there's anything I can do, if there's something you want me to do or something that you want special, I'd be happy to do it for you. So those are things that you have to be thinking about. Loss of that ideal, we kind of talked about all those, but just monitor their grief. Avoid any patronizing statements like, oh, you can have another one, or, the next one will be okay, or this will be okay, or that'll be okay, because in their eyes, that's probably not going to be okay. Malattachment. So here's another thing that can happen. You get a mom that has a baby and she does not bond with the baby. So that bonding should start during pregnancy, and it should continue through that pregnancy. It should continue postpartum. But sometimes these moms don't always have that bond. Maybe they are very young. Maybe they don't have a good support system and they just never bond with that baby. They won't provide eye contact. They don't talk to it, or they don't respond to the baby's cues. They don't want to change the diaper. They want the nurses to watch it at the nurse's station. So if you ever suspect something like that, just make sure it gets reported to the nurses and to the physician and social services, because we may need to get something in there to help with that. So these are just things that you're going to see. This is where your babies are attaching. Moms are, when you can kind of see it, because I've seen it. I haven't seen it very often, but I've seen where the mom, you've seen the moms that hold the baby and the babies just automatically calm down when the mom holds them and talks to them. These are the babies that don't. These are the babies that don't, and the moms just ignore them. They don't want to have anything to do with them. They might say, "You pooped again. What is wrong with you?" Or say kind of derogatory names to them. So just make sure that you're aware of those kinds of things, and report anything like that you might see that might be abnormal. And that is the end